Welcome back to Therapeutics. In this block, we'll cover the antiarrhythmics. Our focus here will be primarily the drugs to control arrhythmias. The most common of all of the arrhythmias you're likely to see in practice is atrial fibrillation. And in atrial fib, we really worry about two things. One is the rhythm issues involved in AFib, but secondly, we worry about clot risks. So I encourage you to go back if you haven't already to also review the antithrombotics guidelines as it relates to atrial fibrillation from the 2018 updates. We'll also spend a little time in this block reviewing the drugs used for ACLS. As in most programs, ACLS training happens at a specific point in the curriculum. We'll review those drugs here quickly. Encourage you, when you get to that point in the curriculum, that you'll get the chance to go back and look at this content briefly as it relates to your studying for ACLS. So let's quickly look at some overviews of electrophysiology and then to see where these drugs fit. So as we think about the normal electrophysiology, so if we think of heart failure, for example, as the plumbing part of cardiology, we consider cardiac rhythms and dysrhythmias or arrhythmias as the electrical portion of it. And we think of the electrical stimulation required to initiate a heartbeat starts at the SA node. There is electrical impulse that travels across the atria and then slows down through the AV node, ultimately reaching the His Purkinje fibers to complete the electrical current. The reason for the atria electrical stimulation and then ultimately leading to contraction of the atria and then a slowing through the AV node, a delay through the AV node before the ventricles fire, is so that the atria can contract, allow the ventricles to fill with blood, so you get a good amount of ventricular fill, so your ejection fraction could then be high, when ultimately, once the AV node delay is over and the electrical stimulation hits the His Purkinje fibers, the ventricles contract in unison when they are already full. As we think of the myocardial muscle itself, really the myocardium responds to stimulation by depolarization of the membrane, and then it's really when calcium enters in the cardiac cells that you have the shortening of the actin-myosin, the contractile proteins, that results in almost an all-in-one contraction. And skeletal muscle contracts, the muscles contract independently in a graded way. So that allows you to have fluid movement. So for example, imagine you're clenching your fist and you're moving your arm up toward your shoulder. You can have a fluid, controlled, only some muscles contract, not all at once. With cardiac muscle, though, we see that as a more unified contraction. And that's because what you want is you want all of the power of the muscle contraction in the atria to contract all at once to allow for ventricular filling. And then after a period of time that when the ventricles are filled, then you want the ventricles to contract in unison to allow the blood to pump out, let's say if it's the left ventricle, throughout the body. Keep in mind that also cardiac muscle contain special cells that exhibit this concept of automaticity. You probably remember this from anatomy and physiology, that they will intrinsically generate their own rhythm in the absence of an external stimuli. And that's a good thing and that's a bad thing. So what we find with certain folks who have cardiac arrhythmias is that if there is a long delay between firing, that those tissues can fire themselves out of sequence, and it's really out of sequence firing that is very problematic in that our concerns are going to be that we're going to lose cardiac output because we don't have a synchronized atrial beat to fill the ventricles, and then once the ventricles are filled, the ventricular beat to pump out and give us a good ejection fraction. Let's talk about the action potential. The action potential in cardiac muscles basically is a change in the membrane potential, the charge outside versus inside the cell. And that really, the nature of the spontaneous intrinsic rhythm is generated by pacemaker cells in the SA node primarily, but also in the AV node. The cardiac action potential is really divided into 5 phases. We have phase 0, 1, 2, 3, and 4. So the other thing we want to think about is if we think of that the action potential is nothing more than the differences between the charge outside the cardiac cell versus inside the cardiac cell at any point in time, then how do those charges arise? Those charges arise from 3 ions, 3 electrically charged substances. Those are sodium, potassium, and calcium. And so the amount of sodium or potassium or calcium at any moment in time that is outside the cardiac cell versus that is inside the cell is going to influence where we are in that action potential. Is the charge more or less equal inside and outside, or is there a difference between what the charge is inside and outside the cell? Ultimately, we're going to look at that differences and how sodium or potassium or calcium are going to enter through cells or leave the cell is going to be a function of channels, and those channels are gated, or a pump system that affects calcium and sodium and potassium. So all of those are going to be driven across or allowed to come across the membrane of the cardiac cells to change that action potential over time. So these channels are very specific for sodium, potassium, or calcium, more or less gates, and the gates are controlled either by a voltage or by a metabolic condition, or by metabolic condition we could mean that there's a receptor also at that gate that allows those ions to enter or not. So let's first talk about calcium, and why we first talk about calcium is because calcium ultimately is what causes the muscle contraction in the heart. So calcium, once calcium enters into the cell and there's enough free calcium within the cell, then you'll see the actin-myosin layers contract and contraction happens. So it's calcium that really leads ultimately to the physical contraction happening. The force of contraction, it's directly related to the amount of this free calcium within the cell. There are 2 sources of calcium in the cell. There is the extracellular outside the cell that enters into the cell via the voltage-sensitive calcium channels. There is also calcium that's bound up in sarcoplastic reticulum and in mitochondria that would ultimately be freed, hopefully at the same point that the channel opens, to allow this large amount of calcium in the intracellular space to allow for contraction to happen. Calcium then has to get into the cell. Calcium also has to leave the cell or become bound up within the cell again at the end of contraction, and that happens via a sodium-calcium exchange. We'll talk about the sodium-potassium ATPase pump that also inadvertently also affects sodium and potassium, sodium, and calcium. And also we have a reuptake of calcium by the sarcoplastic reticulum and the mitochondria as well inside the cell. So here's a more or less pictorial of that. You can see calcium can enter into the cell via the calcium channel, but that calcium gets out of the cell and is replaced by sodium, and sodium exits the cell replaced by potassium, and that sodium-potassium pump is energy dependent. That is the sodium-potassium ATPase pump. We talked about that briefly in the last block, and we'll talk about it again briefly today with digoxin. And digoxin has its effect on that sodium-potassium ATPase pump. It's that elevated amount of calcium in the cell, though, ultimately, the calcium stores that are in the cell getting released, the free calcium get released from the intercellular stores, as well as calcium entering from outside the cell, that ultimately gets those myophils to contract and cause contraction. We also think about sodium. Sodium, when we get to the action potential in a couple of minutes, sodium really starts off this game. For each beat, sodium is the first ion that changes in the electrical charges, and it's a sequence of sodium, potassium, and calcium, almost this dance that they do, that results in the action potential and calcium rushing eventually into the cell. There are sodium channels on the surface of cardiac cells, and there's a receptor at that sodium channel that allows that channel to open up or not. And it's important for maintaining the action potential. There are receptors for some antiarrhythmic drugs on this sodium channel. There are basically the electrical charge will control the degree to which that sodium will enter into the cell. So let's now talk about the action potential itself, and then we'll layer on it the role of sodium and calcium and to some degree potassium as well. So if we look at the classic image of what you see of as the action potential, we're going to focus on what the action potential looks like pretty much from the ventricular point of view, from the ventricle, but look also at the PQRST on an EKG. So we'll see that when the depolarization happens in the atria, that represents the P wave, and the QRS is the depolarization of the ventricles, and the T wave represents the repolarization of the ventricles, and let's focus on the ventricles. So as we look first, initially, you'll notice that when we look at the ventricular action potential in the upper right-hand corner here, that there is a net negative charge from the charge of what's outside versus what is inside the cell. And keep in mind that there's a lot of excessive sodium outside the cell at this point in the action potential. And so the net charge is a negative, usually negative 85 or so millivolts. And then as the ventricles become quickly depolarized, represented by the QRS curve, what we end up seeing is that there is an influx, a massive influx of sodium to start with, and that influx results in a relatively neutral charge inside and outside the cell. And then in phase 2, we'll talk about in a couple minutes, in the early repolarization phase, you'll see that the net charge difference inside and outside the cell is not much different, but the ions themselves may be different. We'll talk about that in a minute. And then in phase 3 and ultimately phase 4, in mid and late repolarization, ultimately what you've got is the net pumping of positively charged ions out of the cell. And what you end up with is to get back to the baseline net negative 85 millivolt charge difference between inside and outside the cell. And that's all correlated from, if we look just at, just the ventricle here, with the just before the QRS, and then the T wave, and what's going on with charges in each of those points. So let's reiterate that again. The P wave represents the depolarization of the atria. We're going to focus on the ventricular action potential, but you could say there's an action potential that happens in the atria that mimics what you see in the ventricle. It's just not lined up the way this is. So if you look just due north or directly above the P on the P wave in this graphic, you'll see that the ventricular action potential is still at about a negative 85 millivolts, and that is an action potential still in the ventricular action potential of 0. When we get the QRS going on, you see right at the point of the Q, you initiate depolarization because the current has gone through the AV node, and you'll see that all of a sudden you have a massive influx of sodium and the charge becomes neutral. And that happens very quickly with the full ventricular contraction in phase 1 and and what you basically have is the phase 1 to phase 2, the contraction of the ventricle happening right then and there. Finally, in the T wave and the repolarization of getting things back to where they can start again, so you have movement of ions back to ultimately their initial places. What you have in the T wave is the T wave, and also by the end of the phase 4 of the ventricular action potential, you are ready for another. Your phase 4 becomes really phase 0 again, ready for another contraction. So let's look at this ventricular action potential from the different points of what's happening with sodium, calcium, and potassium. So early on at phase 0 to phase 1, what we've got going on very quickly here is a major influx of sodium, and when that sodium influx happens to a great degree, what you see is the net charge inside and outside the cardiac cell goes from a negative 85 to 0, because all of those positively charged ions, all that sodium enters into the cell. Once those sodium gates shut close, and there's a little leak of potassium out, and so you see a little, with that little leak, you see right at 1, a sort of a dip in that action potential. Then in phase 2, you have calcium entering the cell while potassium is leaving the cell. And it's that point when that calcium rushes in and the potassium's leaving that you actually have ventricular contraction happening. Then in late phase 3 to phase 4, basically phase 3, you've got all of this potassium leaving the cell, ultimately to get to the point where your net charges are becoming like they are in phase 0, negative 85, but the ions are not necessarily on the right side. So in late repolarization, what you've got is the sodium-potassium energy-dependent pump pumping out sodium and allowing potassium in the cell, as well as calcium leaving in exchange for sodium. So you can see that that sodium-potassium ATPase pump has to work pretty hard, because it has to pump back all of the sodium that happened early on at phase 0, but it also has to pump back some of the sodium that's coming in exchange to get that calcium out as well. So let's first now talk about phase 0. Phase 0, the sodium channels open up, results in a fast inward current, and that upstroke ends as sodium channels are rapidly inactivated. So that's the very first phase. And so there are antiarrhythmic drugs that affect the ability of the sodium channel to open up and allow sodium in, and that's basically how some of those sodium channel affecting agents can work. Ultimately, at the end of phase 1, the mini partial repolarization, and that's kind of it's a very minimal repolarization at that point, is the small leak or transfer of potassium out of the cell. Phase 2 is the plateau phase. This is when contraction happens because the inflow of calcium into the cardiac cell and the outflow of potassium. So in phase 2, the net charges don't change from where they were at phase 1, more or less. They end up with a neutral charge inside and outside the cell. In early repolarization, the calcium channels have closed, the potassium channel opens up, and the potassium leaking out of the cell or getting out of the cell ultimately ends up with the net charges being where they were at the start of this. But again, keep in mind that the ions are on the wrong side. They're not ready to get fire again because there's not enough sodium outside the cell. There's not enough potassium inside the cell, and all that calcium is also inside the cell, not outside the cell. So it's this late repolarization involving the sodium-potassium ATPase pump as well as the calcium and sodium exchanges that get everything back to their baseline. Keep in mind also that the myocardial cells themselves can be very excitable. Their resting membrane potential reaches a critical voltage, and then once that current propagates, you can fire again as long as you're ready. So once you've got the cell ready at phase zero, they're trigger happy to fire again when they get a stimulation. So once that happens, that affects why the conduction and the current and the transmission, what you have is a spread across cells, across one cell with conduction, across many cells with transmission. That's why you have this ready to fire ventricular His-Purkinje fiber firing happening pretty dramatically. All right, so before we look at how these drugs are used and what we're using for drug therapy, let's spend just a couple of minutes looking at reviewing and controlling factors that affect dysrhythmias in patients. So before we add a drug to treat a dysrhythmia, we first look at what are the risk factors for causing dysrhythmias and address those first. So let's look at some factors that affect cardiac rhythm. We're always going to be concerned about electrolyte imbalance, particularly potassium, magnesium, and calcium. These three are critical in folks who have dysrhythmias. And so when you're in a situation in clinical practice that, let's say you're working in an intensive care unit or you work in a coronary care unit, when we look at somebody who's at risk for cardiac arrhythmias, one of the first things we do is we measure their electrolytes and make sure their potassium is not either too high or too low. We correct the low potassium. We also have interventions for managing hyperkalemia. We'll talk about those strategies later on in the year. We also worry about magnesium, particularly low levels of magnesium, and hypomagnesemia is associated with increased risk for ventricular arrhythmias, particularly torsades. And so we're going to make sure we replace adequately that magnesium as well. And finally, we're also concerned about calcium. And calcium is cardioprotective. And so for folks who have certain types of cardiac rhythm issues, we often will make sure that calcium levels are adequate as well and maybe supplement with intravenous calcium if need be. So electrolytes are probably one of the foremost things you should always think about in folks who are either having cardiac arrhythmias or are at risk for certain cardiac arrhythmias. We're always worried about or looking at thyroid status, particularly hyperthyroid. And hyperthyroid is a risk for, among other things, atrial fibrillation, but other things as well. So folks with cardiac rhythm issues, one of the common differential diagnoses we'll make is to get thyroid function tests to rule out hyperthyroidism. You've always want to think about in the back of your mind, particularly someone who doesn't fit the characterization, as the patient's a little atypical of what you'd expect, of whether or not there's some substance abuse, whether it's alcohol or alcohol withdrawal, or a drug of abuse or withdrawal from a drug of abuse. Even smoking and nicotine can cause some cardiac arrhythmia risks associated with it. The alcohol and the smoking nicotine less so than some of the drugs of abuse, particularly stimulants like amphetamines and cocaine are notorious for causing cardiac arrhythmias. So we really want to keep that in the back of your mind if you're seeing somebody with cardiac arrhythmias, are they on a stimulant? You also want to look at their dietary, particularly dietary stimulants, the theobromine or caffeine are going to be issues, as well as whether the patient is under a lot of stress. Physical and emotional stress are also triggers for cardiac arrhythmias. So part of our plan is to sort of look at all of that as we assess cardiac rhythm. Another issue we think about are whether the drug therapy the patient's on affects their rhythm as well. And so we have drugs that prolong QT interval on EKG, and that's a particular risk for developing torsades, ventricular arrhythmias. There are a lot of drugs that prolong QT to differing degrees, and so we keep an eye out for that. We also look at drugs that prolong AV nodal conduction and can cause the risk for second or third degree heart block. And so we'll pay attention to that. You may not have had your EKG readings yet, but AV nodal block will actually use drugs that slow conduction through the AV node in our management of AFib, for example, as a means of a rate rather than rhythm control. And we know that we use that to good, but we can overdo a good thing and use too many drugs that slow AV nodal conduction. We can also see drugs that will elevate heart rate. That can be a problem, particularly for folks who have coronary artery disease, and elevated heart rates are particularly problematic for those subset of folks. And there are a lot of drugs that do that: stimulants, caffeine, theophylline. A number of drugs elevate heart rate. We need to be aware of that. We also have drugs that decrease heart rate or that have negative inotropic effects, which could be problems, for example, with folks with heart failure, affecting or decreasing cardiac output. So let's look at some of those drugs that we need to look at first to take away before we add on more drug therapy. So there are a number of drugs that prolong QT interval. This prolonged depolarization and repolarization of the ventricle is a risk for ventricular arrhythmias. And so we need to be worried about folks who have an excessively prolonged QT or a QTC interval on their EKG. There are a number of drugs that can do that. So as pharmacists, we're always or often looking at this issue, particularly in our ICU setting for folks who have prolonged QT intervals. I'm going to look at their risk for ventricular arrhythmias and which drugs they're on that pose that risk. So there are resources that I encourage you to go to. One is called Credible Meds that I'd encourage you to go look at and become a registered in. You have to register to really get access to this data, but they'll give you updated information about which drugs prolong QT, what their differential risks are. There are some that are very high risk, some that are less high risk. And for folks who have prolonged QTs pre-existing, or for folks who are on multiple drugs that can prolong QT interval, that becomes an issue, an important issue. So let's look at some of those drugs that prolong QT. There are many of them. There are a couple of pages of these drugs, but we'll talk more about these, particularly when we get to the mental health block. There are drugs that prolong QT we use in almost all areas of practice. In mental health, the antipsychotics we'll talk about, there are many of them that can prolong QT. Some of the antidepressants can prolong QT as well. In infectious disease, the two major drugs that will prolong QT dramatically are the macrolides like erythromycin or azithromycin. We use azithromycin a lot. And also the fluoroquinolones like livaquin and ciprofloxacin prolong QT. And so we're really careful about QT prolongation, particularly in folks who are on either of those two antibiotics. And we don't use azithro and a fluoroquinolone together for many patients, partly because of that risk for prolonged QT. Many drugs listed here, and we'll talk about them. Let's talk about some of the higher risk drugs in the next few slides. So here are some of the drugs we'll talk about in alphabetical order. I've boxed them off. And now at this point in the curriculum, I think it's important that you begin to have some familiarity with these drugs. And if you've seen them already, go back and you know, think about one of the things you just think about when you see these drugs are they can prolong QT, and is that an issue for my patient? So amiodarone is an antiarrhythmic drug, so we'll talk about that in a little bit. And it might seem ironic to you that the very drug we use to treat arrhythmias can pose a risk for arrhythmias. That's very true, and we'll talk about that in a bit. So antiarrhythmic drugs, we are careful in using them and usually leave our decision for those drugs to the cardiologists who have experience in electrophysiology. We already talked about the antibiotic azithromycin and ciprofloxacin as drugs that prolong QT. That's pretty dramatic. Clarithromycin, like azithromycin, a macrolide, prolongs QT. Citalopram, which is an SSRI antidepressant, selective serotonin reuptake inhibitor antidepressant, prolongs QT, probably less so than some of the other drugs on this list, but still important. And I've just highlighted the drugs that are more widely used in clinical practice as I see it. A drug we use for Alzheimer's dementia, Aricept, can prolong QT. Droperidol is an antiemetic drug that is related to the antipsychotic drugs like Haldol. We'll talk about that in a bit. Haldol, also a drug that prolongs QT. Escitalopram or Lexapro prolongs QT. Fluconazole. Fluconazole is notorious as an antifungal drug for prolonging QT and also for prolonging or affecting interactions with other drugs that also prolong QT. So it is kind of a double whammy there. If you remember, the azole antifungals are associated with a lot of cytochrome P450-3A4 interactions, raising the levels of those other 3A4 metabolized drugs. And if that other 3A4 drug also prolongs QT, you've got a triple whammy. So Haldol, we still use Haldol a fair amount. It's an older antipsychotic. That will prolong QT. We get careful about that in patients who have pre-existing cardiac arrhythmias or electrolyte imbalances. Levofloxacin, we've already talked about as a fluoroquinolone antibiotic, as is moxifloxacin. Methadone, something people don't often think about. Methadone prolongs QT pretty dramatically. And so folks who are on methadone for methadone maintenance, when we add on other drugs that prolong QT, we need to probably get an EKG and confirm that their QT is not overly prolonged. A very common antiemetic we'll talk about in the GI block later next year, ondansetron, is known to prolong QT. The propofol, which is an anesthetic, we use propofol pretty frequently. That can prolong QT. The sevoflurane that's used as part of anesthetic gases can. Sotalol, we'll talk about sotalol a bit here, and sotalol as a unique type of beta blocker that is also used, primarily used for certain cardiac arrhythmias. We don't really use it for lowering blood pressure or heart rate per se. It has a specific role as an antiarrhythmic beta blocker. So I'd encourage you to go to the crediblemeds.org site, poke around it a little bit, get yourself registered, get a sense of what that resource is, and have that resource available to yourself in practice. And they do updates every couple of weeks or months with adding new drugs or filing or recategorizing drugs over time to help clinicians realize that. This data also that is here is also embedded usually in drug interaction alerts when you're using software. So if you're using a software independent, like on your mobile device, to run a list of all the meds your patient's getting, usually embedded in that is prolonged QT interval drugs that are additive. And so that should be in your interaction software. If you work in a setting where they have a full electronic medical record where you're putting in drugs to the patient's electronic medical record, there should also be alerts for interactions. And if there are two drugs that prolong QT dramatically, you will often get alert on that as well. All right, so what are some of the issues with usually prolonged QT? And we'll come back and talk about this in the mental health block as well. But here was an interesting study done almost a decade ago, recognizing the risk for atypical antipsychotic drugs and the risk for sudden cardiac death. And they found a correlation between the drugs that folks use, pretty much the atypical agents or even the typical agents they use, and their risk for sudden cardiac death. And that is also a correlation, as we'll see in the next slide, of the dose that's used. So lower doses pose a lower risk for cardiac arrhythmias and sudden cardiac death than higher doses do. So what's really concerning for us in practice is when we use drugs that prolong QT in high doses or additive with other drugs that prolong QT, particularly in a patient who has an electrolyte disorder and a predisposition for arrhythmias, that is a setup for a nightmare for ventricular arrhythmias that could be leading to sudden cardiac death. And so as clinicians, one of the things we absolutely need to focus on are to first look at where we are right now, where that patient is right now, what's their risk right now, and instead of treating a problem, we look at whether or not we can eliminate a problem by reducing some of the drug therapy they have. So here's another chart from that same graphic that looks at various agents and their risk for sudden cardiac death based on a low, moderate, or high dose. Let's look at some other cardiac rhythm issues that can happen with drugs. There are a number of drugs that slow conduction through the AV node. Two of the calcium channel blockers do, verapamil and diltiazem. You remember we talked about those as non-dihydropyridine calcium channel blockers. The beta blockers do, and digoxin does. And so for folks who have AFib, for example, where we're looking at rate control, that someone with AFib who has a rapid rhythm, one of the concerns we've got is that ventricular rate could be too rapid, and we need to slow that down. That could be done either with an antiarrhythmic drug to try to get them back in normal sinus rhythm, or one of these drugs that is what's called rate control. We'll use these drugs to slow down AV nodal conduction, but keep in mind that you can have too much of a good thing, that you could slow down AV nodal conduction so much so that in fact the ventricles wait for that beat too long and they start their automaticity. They start firing on their own because they've waited too long for a signal through the AV node. And so we're worried about too much of a good thing. We also have drugs that increase heart rate. Those are particularly problematic in folks with coronary artery disease. Stimulants, amphetamines, beta agonists do, theophylline does. And keep in mind, if you don't have somebody on a beta blocker and you're treating their hypertension, which is often what we do, we don't usually use beta blockers as first-line therapy, the hypotensive agents can sometimes result in a reflex tachycardia. We also see this reflex tachycardia very commonly in someone who's dehydrated. And so we rehydrate them, and lo and behold, their reflex tachycardia improves. So before we start treating arrhythmias, the things we want to look at, in summary, are to rule out electrolyte abnormalities. You want to keep their potassium between 4 and 5. You want to keep their magnesium level above 2. You want to rule out thyroid dysfunction, particularly hyperthyroid states. You want to confirm if they're bradycardic or if they have AV block. Are they on a beta blocker? Are they on calcium channel blockers? Are they on ditch? If you've got somebody who has a prolonged QT, particularly if their QTC is above 500, they're at risk for torsades. You want to look at the drugs they're on. You want to manage their electrolytes and keep all of that in check or in mind. Okay, let's look at some of the specific antiarrhythmic drugs that you may use in practice. Many of these drugs are actually you're not going to see used very often, but we'll fill you in on the framework of how they work and the different classes of drugs that are used. But we will focus in our time on the 2 or 3 agents that you'll see used more frequently. So let's look at the antiarrhythmics, and we think of the drugs. First of all, arrhythmias, you'll see them very commonly in practice. About a quarter of the patients who are on digoxin will have a cardiac arrhythmia. Usually they're minor. Usually it's significant AV nodal conduction issue, which is why we're using dig probably in the first place, but that can be a problem. Many of the patients who undergo anesthesia in surgery may have arrhythmias in that procedure, and that's certainly of concern. And 4 out of 5 patients who have an acute MI probably have an arrhythmia associated with that MI. So important for us to recognize they're pretty common to see arrhythmias in practice. They often require treatment, particularly if they're too slow or too fast or asynchronous. That affects cardiac output. And so just recognize, if you recognize that, then you recognize the critical importance of why we need to treat these. These are life-threatening because you can end up with a cardiac input of 0 with VFib, and that's not sustainable with life. We also have premature ventricular depolarizations or early types of arrhythmias that can compound and lead to more significant ventricular fibrillation. So VTAC can lead to VFib, and so we're concerned about avoiding VTAC before we get to VFib, and both even VTAC very significant as well. And keeping in mind, and we alluded to this already once, is that the drugs we use to treat arrhythmias themselves can actually cause arrhythmias. And so one of the reasons why many of these drugs are not used as much anymore as they used to be is that in the late 1990s, there were actually data that called the CAST trial, that the very drugs that will make an EKG look better actually are associated with more mortality for those patients. And so we'll talk briefly about them, but there are really limited drugs that we use for arrhythmias in these days most commonly. And almost always with most of these drugs, they're going to be ordered not just by a cardiologist, but by an electrophysiologist, a cardiologist who specializes in cardiac rhythms and may actually bring the patient to their setting to actually test their arrhythmic and antiarrhythmic potential of which drug is a better choice for that patient in a controlled environment. So it's pretty common in practice that folks will, when they talk about antiarrhythmics, will refer to the Vaughan Williams classification of antiarrhythmic drugs. And this is not totally inclusive, this list. There are other antiarrhythmics that don't fall into these four categories, but these are the sort of the classic four categories that people think about when they think about antiarrhythmic drugs. There's class 1, class 2, class 3, and class 4. And class 1 drugs are sodium channel blockers, and there are subgroups of these, 1A, 1B, 1C. 1A has an intermediate effect, 1B fast, and 1C slow effects. And so each of these agents in the 1A class, 1B class, and 1C class are differentiating from each of the subclasses, but more similar to each other. Of all of the drugs that are used in the class 1 agents, we don't see them used very much. The class 1 drugs we don't use very much at all. The only drug that we rarely still see used, and even that is rare, is procainamide. And so it may be used for atrial or ventricular arrhythmias, but again, it's considered by many a second or third line agent these days. We used to see a lot more of it used maybe 2 decades ago. Of the 1B agents, really the agent you'll see used most often here is probably lidocaine. And most often you think of lidocaine not as an antiarrhythmic, but as an agent for a local anesthetic. And so it will have effect conduction and nerve conduction, and that's as well as cardiac conduction. So it has a role there. We still see lidocaine showing up in ACLS lists of protocols, but it really is a second-line agent these days. We can use it for ventricular arrhythmias, but again, it's second-line to really better choices like amiodarone we'll talk about in a bit. The 1C agents have a unique role. They're effective for supraventricular arrhythmias, flecainide, propafenone, and these drugs, for folks who have supraventricular or risk for ventricular arrhythmias, an electrophysiologist may order them, either flecainide or propafenone. You'll see them used on occasion as a primary care provider or as a PA who is working with a physician who is not an electrophysiologist. You probably will never be newly ordering these drugs. What you will see, though, is occasionally patients who are on them that you will continue them as part of your medication reconciliation. And so recognizing that flecainide and propafenone have a clear role for preventing arrhythmias, but you want to make sure that they're followed carefully by their cardiologist and also that their electrolytes are in good shape, that you don't want them to have a low magnesium or a low or high potassium or a low calcium while they're on these drugs, because that predisposes them to ventricular arrhythmias, both from their baseline underlying need for the drug in the first place, but also because these drugs could be pro-arrhythmic in an electrolyte abnormal situation. The class 2 drugs, the beta blockers, are most often used for AV nodal conduction when we use them as an antiarrhythmic. They have an effect on the AV node, particularly they also lower heart rate, so we use them for tachyarrhythmias. So they're used in subsets here. The class 3 drugs affect potassium channels. They are potassium channel blockers. And of all of the drugs that are listed here, probably the one you'll see most often used is amiodarone. Amiodarone is used for atrial and ventricular arrhythmias. It will prolong the QT, though, and so many of these drugs prolong QT. We saw that with the 1A drugs above. We saw lots of other QT prolonging drugs earlier in this presentation. But amiodarone prolongs QT, so we have to keep that in mind if somebody has a prolonged QT to start with. But amiodarone, of all of the drugs that are in the class 1, 2, or 3 group at least. Amiodarone is the one you're going to see used most often. And most often in clinical practice, we will use amiodarone as our first-line drug for patients for whom we are looking, who have AFib with a rapid ventricular response, where we're looking at what we're going to call rhythm control. That our goal is not to slow their conduction through the AV node, but actually try to return them to normal sinus rhythm. There are risks and benefits for doing that. We'll talk about that in about 15 or 20 minutes ahead when we talk about our management of AFib. Other drugs that are in the class 3 grouping is including down here, the third drug on this list in this table is sotalol. Sotalol, a type of beta blocker, but unique among the beta blockers. It's not really the classic class 2 beta blocker at all. It really has more of an effect on prolonging refractory period and has an effect on QT used for ventricular arrhythmias. And sotalol, again, is a drug that we need to be cautious with and is going to be ordered likely by an electrophysiologist, not by you, at least not starting with you. Other drugs that are on here, difetilide is a drug with lots of drug interactions, a class 3 agent that, again, rarely is used, but occasionally we'll see patients on that. Of the class 4 drugs are the calcium channel blockers, diltiazem and verapamil. We use these primarily for slowing AV nodal conduction. That's the primary reason why we'll use them as an antiarrhythmic. They will decrease heart rate, increase the PR interval, prolonging AV nodal, slowing AV nodal conduction. And so these are going to be the drugs, diltiazem in particular, is going to be the drug we're going to go to when we want rate control in atrial fibrillation. And that will slow AV nodal conduction, but the person still won't be in normal sinus rhythm. So these groups is sort of a reiteration of the table we just talked about. The groups 1, A, B, C, group 2, 3, and 4. Also, this chart, we list those. Another way to look at those same issues is what effects they have on affecting which phase of depolarization or repolarization, where the 1A slows the phase 0 depolarization, where you'll see other effects for the other antiarrhythmics in this class. Not essential really that you memorize or know that, just recognize that there is a mechanism behind how these drugs work and where they fit in clinical practice. The issues here that are take home on this classification of conduction, velocity, refractory period, automaticity, what really is important is probably the last column over here, what slows AV nodal conduction. And that's going to be a concern for which drugs we're going to use. For example, in AFib for rate control, it should not surprise you that we're going to use category 2 drugs, the beta blockers, and category 4 drugs, the non-dihydropyridine calcium channel blockers, to slow AV nodal conduction. So let's look at the sodium channel as it relates to giving antiarrhythmics. We talked about the sodium channel as the phase 0 channel that opens up and allows sodium quickly into the cell and allows for the initial depolarization of the cell going from a -85 to a 0. And the anti-arrhythmia drugs that we had listed here in the group 1 drugs are listed here, and you'll see the kind of onset and effects of those drugs. Virtually all of these drugs, though, in clinical practice, we don't use very often. Almost always when these are ordered, they're going to be ordered by a electrophysiology cardiologist. And so you don't need to necessarily spend a ton of time on this, just have a little recognition that these are drugs you may occasionally see in clinical practice. So of these drugs, let me pick the ones that I think are more likely to see are the class 1C agents, propafenone and flecainide. And I alluded to earlier a set of trials that were done in the early 1990s, and we used to use drugs in the 1C class much more frequently than we do now because, in fact, while they will improve certain parameters on their EKG for folks who have cardiac arrhythmias, For some patients, these actually will result in increased mortality. And so the cardiologist is going to be very specific about which agents they pick, when they pick one of these, and how they do it. These drugs, propafenone and flecainide, can be used for converting folks from AFib to normal sinus rhythm, and that's one of the more common issues we'll see. We'll look at when we convert somebody, typically they'll be on a higher dose, and then when we're trying to keep them in normal sinus rhythm, that dose will go down. So propafenone or flecainide could be used for those folks, but what in practice you're likely to see is we'll talk more about amiodarone in a minute, and that's the more common agent we're going to use to get someone in normal sinus rhythm who has atrial fibrillation. The class 3 drugs block potassium channels, so let's talk about where these drugs. The biggest group in the group 3 that you will see is amiodarone, and so that's the one we're going to focus on. We'll also talk briefly beta blockers, propranolol. We don't really use propranolol much anymore in cardiology, but we could use metoprolol to slow AV nodal conduction. We do that a lot. And the group 4 drugs that are listed here, the one you'll see used most often is diltiazem. The other one you'll see, and we'll talk briefly about, is adenosine, and whether or not we really call that a group 4 drug or not depends on how different people may classify it. We'll talk more about each of these drugs specifically. But let's focus more on the group 3 drug, amiodarone. So amiodarone is a pretty effective drug at affecting potassium, but it has other subtle effects as well. We'll see it has effect on calcium channels and has effect on alpha and beta effects as well. It primarily is going to be used for folks who have VFib or VTAC, and or folks in AFib, getting them to normal sinus rhythm. It is, however, a problem for folks who already have prolonged QT or folks who have a second or third degree heart block. So we're going to worry about those as contraindications. We also worry about folks who have profound bradycardia already. And there is at least a theoretical risk for amiodarone for folks who have iodine sensitivities. For the most part, I think that's probably been largely refuted. But if somebody has, for example, an allergy to fish or to radio contrast dye, there is, at least in theory, a risk for the iodine that's found, or the iodinated moiety that's found in amiodarone. The adverse effects of amiodarone are hypotension, bradycardia, prolonged QT. It can induce heart failure in some folks. It will interact with a number of drugs. We see it interacting with warfarin. We see it interacting with a number of other drugs. In the IV formulation we give, we need to make sure that the line is flushed before we give it. So basically, if somebody has an IV and you're in a code situation giving it, you quickly flush the IV with saline, and then you give them amiodarone and flush it again. It's incompatible with particularly IV sodium bicarb, but with other drugs that you might use. And this is one of the drugs, amiodarone is one of the drugs we use in ACLS. So as you look at it, you'll see some of the adverse effects of amiodarone in this chart. Pulmonary fibrosis is a big one for us. Amiodarone is a very long half-life drug. This drug we need to load early with a high dose as a load, and then this has a half-life of weeks to months. So the half-life on average is 58 days. It has a lot of interactions with the cytochrome P450 drugs. So it has interactions with warfarin, with digoxin, and so we really need to be careful about managing interactions with this drug. It's kind of a little fickle on how we do that, but you'll see this drug used pretty frequently. The classic dose for IV for AFib conversion is listed here in this chart, but we'll also give it orally. And then once folks are maintained on amiodarone, we'll give them a lower dose. For folks in a code situation, we will use aggressive management. Typically what we'll give them is a 300 milligram bolus, then 150 milligram repeat doses until we get them stable, and then give them a continuous infusion after that. So pretty common that we're both for AFib conversion and for our ACLS protocols, we front load amiodarone because it's such a long half-life drug, takes a long time to get to steady state. We have this protocol of very high doses as a bolus, and then moderately high dose infusions for a period of 24 hours, and then a high dose oral for 3 weeks to a month, and then lower dose oral thereafter after the first month of therapy. Sotalol is another antiarrhythmic you may see used. You're not going to order it, but the cardiologist will. It's used for AFib and rhythm control, as well as folks who've had a history of VTAC, and so the protocols and the dosing is there. It's a bit fickle. It has some interactions associated with it. It's renally eliminated, one of the few we do, and we have to hospitalize the patient when we start the drug because of the effect it has on the QT interval. And so we are very careful about when we start somebody on sotalol, we do it in the hospital on continuous electrical monitoring and look at their QT before we start it and while we're starting it because it prolongs QT so dramatically. Quickly, I want you to have familiarity with this drug called dofetilide. We don't use it very much, partly because it is so many drug interactions with it, and there are probably as or more effective alternatives to dofetilide. But occasionally you'll see a cardiologist order it. As soon as you see this drug, you need to run drug interaction checks before you start or stop any drugs for a patient on dofetilide. And ibutylide, an older agent that is still part of some ACLS code protocols. You'll see it rarely used. Most of the time, though, it's a drug of almost historical significance. So let's talk. So those are some of the common drugs. Of all of the antiarrhythmics we've seen so far, the one you will see used most often is amiodarone. The remainder of them you won't see used very much. You will see them occasionally in ACLS protocols or somewhere else for patients coming in with a cardiologist. Let's look at some of the other agents here that are used, and what you should probably have familiar with is adenosine. You need to have familiarity with atropine, with digoxin, with epinephrine, with vasopressin, and with mag sulfate. We're not going to really talk about dopamine. Usually we're going to use that in the management of someone who has maybe possibly septic shock, but most often cardiogenic shock. And we use that more often in heart failure than we use it as a classic antiarrhythmic drug. So let's look first at adenosine. Adenosine affects potassium to some degree. It slows conduction through the AV node. What's dramatic about this is we will use this drug for converting somebody with paroxysmal supraventricular tachyarrhythmias to normal sinus rhythm, and it may convert that. Sort of careful with folks with Wolff-Parkinson-White syndrome. But it's not going to be effective for folks with AFib or A-flutter. So for folks who have PSVT, this adenosine does make sense. It's a very unique drug. It would be contraindicated in folks who have slowed AV nodal conduction already, second or third degree heart block, and also contraindicated in folks with AFib or A-flutter. Particularly if they have associated ventricular tachyarrhythmia, it's only appropriate for supraventricular tachyarrhythmias. It has this very short half-life. Its half-life is 6 to 12 seconds. Very short half-life drug. And so when we give this drug, we need to give it IV push, but you have a saline bolus. So you flush the line with saline. You give this drug as quickly IV push as you can. Usually 6 milligrams. Sometimes we double the dose at 12 if they haven't got a response to 6 milligrams. And then you flush the line with another 10 mLs or 10 cc's of normal saline again, so that the drug isn't sitting in the IV line, the drug is in the patient, that you're pushing the drug along with the added saline post-bolus. Patients, though, will have a pretty dramatic response, and you're sitting with this patient with the EKG running. And what patients will experience often is a dramatic response with facial flushing, shortness of breath, chest pain, and then you look over at their EKG and you will see it look like it's flatlined for 10, 15, 20 seconds, sometimes longer. Those will be the longest 20 seconds in your professional career because you think the person has just died. Then they will come back, and it's pretty rewarding and dramatic when you see their response to adenosine. You also, though, have to tell a patient that you're going to be very uncomfortable for about 20 minutes. We're right with you. If they're conscious and alert, you need to tell them that. And that this drug will make you feel for 15 or 20 seconds that you're going to die. But you say it in a way that doesn't say that. You say this is a drug that's going to make you feel like you've got facial flushing. You're going to have difficulty breathing. You might have some chest pain. You're going to have some headache. We're right with you. We're right here taking care of you, and it only lasts for 15, 20 seconds or so, and then it'll be over. So we're right with you. If there's somebody else in the room, can hold their hand or something, do that, and they'll be fine. But give them a lot of reassurance when you're doing it. There are a number of interactions with other drugs that are listed here, particularly the methylxanthines. Caffeine and theophylline antagonize the effect, and so those folks may need higher doses of adenosine to get the response you want. But it has its onset in peak effects pretty quickly, pretty rapidly, usually within 45 seconds to a minute. Hopefully the patient's responded well and they're back in normal sinus rhythm. Let's go to atropine. Atropine is used to enhance SA node, and so we'll use this for its vagolytic actions. It's used for bradycardias. It will induce tachyarrhythmias, so you want to be careful about folks who have coronary artery disease. You want to be careful about folks who also have anticholinergic syndrome. If they have flushing, tachycardia already, this is not the drug for them. And it may actually induce VFib and VTAC, so we want to be careful when we're using it for folks with coronary artery disease already. It's a category C drug in pregnancy in the old standards. You'll see pretty much a dilation of pupils when you see it used. Okay, let's quickly talk about digoxin. In lower doses, we talked about this in the earlier block, lower doses you'll see an increase in calcium in the cell, which is great for its inotropic effects in folks with heart failure, strengthening heartbeat by strengthening contraction, and used in heart failure because of that strengthening contraction, although keep in mind we mentioned there wasn't really an improved mortality with that benefit. In higher levels, though, digoxin begins to slow conduction through the AV node. And so we'll use dig in higher doses for folks who have AFib when our goal is not to get them to normal sinus rhythm, but instead when our goal is rate control, that we want to slow this rapid ventricular response for someone with AFib. So we talked about dig, narrow therapeutic index drug. In the heart failure block, I'm not going to reiterate a lot of those issues. We need to be careful about their renal function, that we look at their renal function, because if they go into renal failure, they will accumulate dig and become dig toxic. Epinephrine, we talked about epinephrine before. We'll talk about it here again, both alpha and beta agonist. Alpha causing bronchodilation, beta 1 having effect on inotropic and chronotropic actions in the heart, increasing automaticity, and in beta 2 for bronchial smooth muscle relaxation. So when we use epinephrine for someone who has anaphylaxis, our classic situation there is we're looking for the alpha and the beta 2 effect. We're looking for vasoconstriction. We're looking for the beta 2 bronchodilation effect. For folks, though, who are in ACLS protocols and code, we use epinephrine IV for its positive inotropic effects and to get the heart beating. And so this is a drug we only give IV epinephrine in this ACLS protocol situation in cardiac arrest or in asystole, never IV for other reasons. You can give it, it's associated and helpful in acute bronchospasm, but we typically use other drugs. In asthma, it will be helpful, but we will use other drugs, not epinephrine usually. And for anaphylaxis and allergic reactions, certainly it does make sense. So we've talked about all of those sort of purposes and reasons before. We're going to focus on epinephrine and its use in ACLS protocols. The concerns with epinephrine for adverse effects, though, are hypertension, hypothermia, pulmonary edema, and coronary insufficiency. All of these are folks where we'd be concerned about using epinephrine. But stop for a moment and think. The only indication we're going to give it for IV use is cardiac arrest or asystole, or maybe electromechanical dissociation or VFib that's not responsive to defibrillation. In those circumstances, there is virtually no contraindication to use because the dire risk of not treating is death. So in those cases, while there are contraindications, the benefit outweighs whatever the risk is because the patient will die without epinephrine. So let's look at the dosing we use for allergic or anaphylactic reactions. We use epinephrine subcutaneously. We don't use it IV. I crossed out the anaphylaxis with the IV dose here because we don't do that. In anaphylaxis, we use subcutaneous. The only time we use IV push epinephrine is for asystole or PEA or ventricular fibrillation per ACLS protocols. And we'll talk about those in a little bit. There is also epinephrine can be used by nebulizer. We'll use this for laryngeal edema or croup by a nebulizer. You'll see this sometimes used. I put this here as a placeholder. It's not really an antiarrhythmic use for the drug, but I put it in there so you have a sense of completeness. Okay, let's talk a minute about vasopressin. Vasopressin is a pituitary hormone used to treat diabetes insipidus, also used for esophageal varices. We've historically used it for cardiac arrest and cardiac arrhythmias. It used to be in the ACLS protocols. It's no longer in the ACLS protocols. And so we don't really spend a lot of time talking about vasopressin and its role in cardiac arrhythmias or ACLS protocols anymore. But it used to be pretty common to see it. There are theoretical advantages for vasopressin in that it's not a it doesn't have effect on myocardial perfusion that epinephrine would, and it's a potent vasoconstrictor. But in clinical practice for ACLS as a drug in a protocol for arrhythmias, we no longer use it. All right, let's move on to yet another antiarrhythmic drug or common drug, magnesium. And magnesium has lots of indications, and in the hospital, we use a lot of mag sulfate, a lot of it. We'll use it in obstetrics for folks who have a risk for preeclampsia or toxemia or pregnancy. It is the drug of choice, and why we include it here in this block, it is the drug of choice for torsades. Someone who has torsades or ventricular arrhythmia, a type of arrhythmia. The EKG looks like a spiraling DNA helix almost. That's classic torsades, and mag sulfate is the drug we use. We'll also prophylactically give mag sulfate to patients who have prolonged QT to make sure that mag levels are above 2. We'll also use mag for anybody with hypomagnesemia. It's a drug of choice for tricyclic antidepressant overdoses. We'll talk a little more about that later in the year. We don't use them very often now, but you'll still see patients on them. We use mag sulfate for DIG-induced arrhythmias, and it's typically also used in any patient with VTAC or VFib. It would be contraindicated in absolute heart block, or it's relatively contraindicated in folks with renal insufficiency, depending on the situation. But if you're dealing with someone with torsades or toxemia pregnancy, the renal issue is quite secondary, and we manage things aggressively. So as far as using MAG, adverse reactions, usually not all that problematic. I think the big concern with MAG sulfate when you use it is hypotension. So if you give MAG very quickly IV, we do see hypotensive reactions, which can be a problem for patients. And so we really titrate that and do that carefully. In addition, MAG sulfate has to be diluted. It's very irritating to the vein, among other things. And so we always give it diluted as a 10% solution. Our dosage typically is anywhere from 1 to 4 grams. In obstetrics, truth be told, we use even more MAG than that. But typically the dose you'll see in the hospital is a gram of MAG sulfate over an hour, or 2 grams over an hour or 2 hours. If you have someone with torsades, though, we will give it diluted very quickly, over even a couple of minutes. And you have to live with the hypotension that's associated with that in a code situation. But if, truth be told, if they're in torsades, they don't have a blood pressure. So you're really managing that aggressively in that circumstance. So quickly, dopamine, as a quick review, dopamine would be primarily indicated for cardiogenic shock, and it would be contraindicated in folks who have hypovolemic shock. First, you replace fluid if their problem is low volume, or if they have some other tachyarrhythmia or issue for which the stimulation of beta 2 receptors aggressively would be problematic. We worry about excessive cardiac stimulation with dopamine, so you keep that in mind. You look at their myocardial oxygen demand. If they've had an MI, we're careful about that. And if they've had a post-MI, we're really careful about how we use dopamine, if we use it at all. But dopamine, we found on the alpha-beta meta, is sort of a little bit more on the beta side. But interesting, as we alluded to, dopamine has varying alpha or beta effects based on the dose we give. So in practice, you'll see that the usual dose is going to be somewhere starting with 2 mics up to maybe 20 or 30 mics per kilogram per minute. And you'll see an onset in pretty quickly, a peak effect pretty quickly, and you can titrate the drip by shutting the infusion off, and all of a sudden the effect almost stops immediately. Those dose response phenomenon we look at are listed on this slide. You'll see that the very low dose, 2 to 4 mics per kilo per minute, we see the dopaminergic vasodilation effect and dilation of the vessels in the kidneys, which may or may not result in some subtle urine output improvement. That is, we used to call this renal dose dopamine, and it used to be universally given in ICU settings when somebody was going into renal failure. But that really, despite the fact that it causes a little bit better perfusion to the renal artery beds at very low doses, it is not associated with any improved outcome. And so for the last 20 years, this has not been a practice. We don't really use that therapeutically, that dopaminergic response. The beta response, we begin to see increased in heart rate and heartbeat in rates of 4 to 10 mics per kilo per minute. And then after above 10, we begin to see some vasoconstriction. Its alpha effect begins to take over. So by titrating the dopamine drip in mics per kilo per minute, you can actually affect the pharmacologic effect that you're looking for. But with a dopamine drip, because it's vasoconstriction, we're always going to have a central line on these folks, because if the line extravasated, if the fluid got out of the vein and into the tissue, that vasoconstriction means necrosis. And so we worry about that extravasation issue. Always on this person would always be on a monitor, and they would always have a pump and a consistent rate administered. Or nursing is really well aware of how to do that in the ICU setting. So we're going to give dopamine drips maybe in the emergency department or in the ICU. We're not going to give it in the hospital on the medical surgical floors. You're certainly not going to give this in the community. The only exception might be on rare cases where we've used palliative dopamine in someone with end-stage heart failure. But even that practice is quite remote. Okay, in your practice, the most common cardiac arrhythmia you will see, and that really its management would fall in your purview, in your domain, is probably atrial fibrillation. And AFib on an EKG, it's classically on a pulse. The pulse would be irregularly irregular, and you can see in EKG that the P waves are just all over the place, and that the QRSs are not equally dispersed, and that's because there is a variation in what gets through the AV node and how that ventricular response is. But typically the ventricular response is variable and rapid. And So as such, we're going to set our goals with AFib related in part to that. So AFib, very common. You'll see it in practice, usually in older folks more commonly than in younger patients. Particularly, you'll see it in folks who have valvular disease or folks who have pre-existing heart failure. It may be asymptomatic, or the patient may have palpitations, chest pain, lightheadedness, or fatigue. And it's classified whether it's paroxysmal, persistent, or permanent, or recurrent. And so that depends on the time course of it and the duration of it. So as you're looking at classic cardiac conduction and AFib, sort of this graphic, I'd encourage you to sort of spend a couple minutes. You can stop the presentation and sort of look through it. Gives you a little bit of what you'd expect to see pathophysiologically with reentrant pathways and the like. With AFib, the classic EKG is going to be no P wave, and the rate is irregularly irregular. And then we're going to have two major goals for our patients with AFib. One is controlling their rate. Because of their ventricular rate, if their ventricular rate gets much above 110, 120, we start to lose cardiac output. And why that is because you remember we talked about in cardiac output is a function of heart rate and stroke volume. And while the heart rate goes up and you think, oh, the cardiac output goes up, if the rate is so fast that the ventricle doesn't allow to fill between beats, then you have nothing to pump. And so we really look at controlling that rate and getting that rate below 100 or 110, even below 90 if we can, is ideal, but certainly below 140. You'll see folks 140, 150, 160 with AFib, and the higher they go, the more detrimental that rate is, and so we get aggressive at that. We can do it by rate control, or sometimes we call rhythm control. And we'll differentiate rate versus rhythm control in a bit, but either way, our goal is to get that ventricular rate down so that we maintain cardiac output and have less chance for ventricular arrhythmias. The second goal of therapy is the risk for clots. And we briefly alluded to this when we talked about antithrombotics in last week. Our role is to prevent clots from forming, and all of that irregular blood flow that is going on in folks with AFib, both in the atria and to some degree in the ventricles as well, predisposes the risk for a clot and then an emboli, and then their risk would be a pulmonary embolism, or probably even more critically and more commonly observed by the size of that clot would be a clot to the brain and a thromboembolic stroke. And so folks with AFib are clearly at risk for thromboembolic stroke. So we're going to control. Our goals are let's get that rate down and let's prevent a clot. So first off, before we start treating, we need to look at what some potential causes are. And there's a list here of things that contribute to AFib. So these are issues when they're controllable that we want to manage them as well. So, for example, if somebody has hypertension, one of our long-range goals is to manage that. That's a risk for AFib because of atrial distension. We can also see that if they have pulmonary hypertension, we can do something about that. If they've had a pulmonary embolism, we can do something about that. If we had a MI, myocardial infarction, we can do that. Sleep apnea, we can look at managing their sleep apnea in a better way. So there are things that are controllable here as potential causes for AFib that we're going to manage those as well as managing their coagulation and their ventricular response. Also, high adrenergic tone states, alcohol withdrawal, any drug withdrawal, frankly, thyrotoxicosis or sepsis, or sympathomimetic uses, or surgery. All of those are increased risks for AFib, and to the extent that we can control those, we'll do that as well. When we look at rate versus rhythm control, you would stop and think, gee, wouldn't our goal always be to put someone in normal sinus rhythm as opposed to just getting their ventricular rate down? Well, yes, but With rhythm control, there are pros and cons to our treatments that we can do that with, and rate control, there are pros and cons. So let's first look at rate control. And in clinical practice, when you've got somebody in front of you with new onset AFib, the first thing we're going to easily do is rate control. So we can do rate control and then look at rhythm control, but almost everybody is going to at least start with rate control. The advantages of rate control, and this is going to be done by using drugs that slow AV nodal conduction. These will be beta blockers like metoprolol, or calcium channel blockers like diltiazem, or maybe digoxin. Those are the big three we're going to use to slow AV nodal conduction and rate control. The pro of rate control, it's easy to achieve, and you can do that whether the patient's in the hospital or out of the hospital. With the downside to rate control is that over time, folks in AFib will have electrical and structural remodeling, and so for younger patients, that's not a ideal circumstance. That for younger patients, below the age of 60, typically we will look at trying to look at an option for rhythm control, if that makes sense. The advantages of rhythm control are, and rhythm control is going to be done, for example, with amiodarone, is that it will improve with symptomatic fatigue for patients. Their symptoms usually improve if their sinus rhythm is normalized, and you'll see less development of structural arterial changes. You can use it in young and old rhythm control. We often will use it more likely in younger patients than older patients. But the adverse effects associated with it are that rhythm control is associated with issues for AFib recurrence. You need an in-hospital stay. And the other issue you absolutely have to consider is to first rule out a blood clot. And that's going to be a key issue for us. If we're looking at rhythm control, you're going to put somebody in normal sinus rhythm. You absolutely, positively must confirm that they haven't had a clot. If the patient has a new onset AFib, this is the very first time they've had AFib, and it's for less than 48 hours, it's likely they don't have a clot, and you could start rhythm control with amiodarone or with shock or with something cardioversion if you needed to. But if they've had AFib for more than 48 hours, their risk for a clot is significant. And if you put them from into rhythm control, into normal sinus rhythm, there is a high likelihood they will throw that clot and they will have a stroke. And so as such, we really need to be very careful about doing that. We want to ensure safe cardioversion for patients, and we would do that either with, for those folks who have been in AFib for more than 40 hours, either get a transesophageal echocardiogram to visualize the aorta and rule out a clot, or to put them on 3 weeks of anticoagulation before we give them rhythm control. The rhythm control can be either electrically shocked or pharmacologically with drugs, and in clinical practice we see drugs used probably more commonly because a shock is pretty disruptive for the patient. The issues or the guidelines listed here for strategies around anticoagulation for cardioversion are listed here. Typically for folks who have a stable duration under 48 hours, typically you'll anticoagulate the patient, and you could start with the type of cardioversion you need to do. For folks who have a no TEE to rule out a clot, then you have to anticoagulate them for 3 weeks as it's listed in this table. The TE-guided cardioversion for stable patients are listed here as well, and how we do a TE-guided therapy, and then we'll still put them on anticoagulation per guidelines. The options for rhythm control in AFib depend on whether or not there's structural heart disease. So if there's no structural heart disease, you could use any of the agents listed here, and sometimes clinicians are, and this is going to be done typically with a cardiologist, you might use one of these agents, flecainide, propafenone, sotalol, or amiodarone. For structural heart disease, if they have heart failure, you're going to use amiodarone. If they're coronary artery disease, often they will also end up with amiodarone as well. So you can see often amiodarone is sort of in the mix here, and many folks will go to amiodarone as a first-line agent. But dofetilide or sotalol or flecainide or propafenone, depending on the circumstances, might be an option as well. We reviewed the CHA2DS2-VASc scoring a bit in the antithrombotic block. As a review here again, folks who have AFib, one of the important things is to make some kind of an assessment about what you think their risk assessment is for a clot and whether or not they need anticoagulation. So the CHA2DS2 scoring is routinely done. The updated CHA2DS2-VASc scoring, a little more complete than the older CHA2DS2 scoring, used to be a few more elements. But you look at the point value, you look at their adjusted stroke rate per year based on their CHA2DS2 score as is predicted from population models, and then go accordingly. The one thing that's changed over the last year in the 2018 guidelines is that no longer with a CHA2DS2 score is aspirin or antiplatelet therapy recommended for a CHA2DS2-VASc score of 1. Typically, oral anticoagulants are the way we go unless there's a contraindication. So we sort of weigh the risk and the benefit. You could make an argument for a patient whose has-bled score is poor, particularly with a CHA2DS2 score of 1, that they may avoid using anticoagulant therapy entirely, but that's a risk-benefit assessment. If their bleeding risk is moderate to low, most clinicians in this day and age, based on the 2018 guidelines, would start oral anticoagulant, usually with a novel agent. The novel agents, as we alluded to in the 2018 guideline review, have the pharmacologic rhythm control in AFib. Amiodarone probably has the highest efficacy, a little troublesome to use, but we require loading doses, as we've alluded to. It's got a very long half-life, so we're going to monitor patients for that. There are lots of interactions with amiodarone, so we want to pay attention to those interactions, and particularly the ones we see are DIG and warfarin. Also the statins, perhaps, the beta blockers, perhaps as well. And we also have to monitor for non-cardiac effects, liver function, thyroid function, and pulmonary function. Particularly, we get concerned about this pulmonary fibrosis. And the problem is if they have any of these problems, well, the issue is just stop amiodarone, sure. But such a long half-life drug, it takes a long time for amiodarone to clear the body, half a year or so for it really to become clear. So important for us to remember that. Sotalol has less efficacy in control, getting folks to normal sinus rhythm, and we have to be careful about the QT prolongation with it. So we started in the hospital. You can do sotalol. Many clinicians will do sotalol in folks who are not candidates for amiodarone because it's not quite as effective and it's a little cumbersome with this QT prolongation issues we have to address or take care of. Dofetilide can be used. It has lots of interactions associated with it, and so it's a drug really of second, third line drug. We don't see it used very much. At least I don't see it used very much in clinical practice, although there are subsets of patients who really have done well on it. Other therapies for rhythm control are pretty rarely used. The class 1 A, B, and C agents rarely used. Androdrenone really not effective and has some serious safety issues with it, so largely has fallen off use entirely. The table for that is listed here, but just suffice to say it's a drug we're not really going to use. Because of these safety issues, really largely the fatality rates are higher. In this day and age, we're not using that. Other things we look at and treating other arrhythmias or other issues in treating arrhythmias were electrolyte disturbances. You want to manage that. Thyroid function, you need to keep an eye on that, as we alluded to. If they have bradyarrhythmias or AV block, you want to rule out whether or not they're on a beta blocker or a DIG that's doing it, and you want to watch out for QT prolonging drugs. So If it's not AFib, all of these are common things you will think about and look at doing in your practice. Okay, let's very quickly just breeze through ACLS. You'll get much more of this later in the year, and so it's not going to be a focus here. It's just kind of an introduction to that. Basically, all I'm going to do is share with you a couple of quick charts. So key components in the ACLS algorithm are to start CPR, and if it's a shockable rhythm, shock. If they have pulseless ventricular tachyarrhythmia or fibrillation, you will look at shocking, CPR, getting their IV access, reassessing where they are. But ultimately, we're looking at epinephrine, IV epinephrine, and reshocking defib, and then going with amiodarone as our protocol or treatment here. So really the two mainstays here are in line 7, epinephrine IV, in addition to when you do defibrillation, and line 10 for amiodarone when amiodarone fits. For asystole or PEA continuing, we'll look at item 11. You'll give them more epinephrine and continue to looking at reassessing rhythm and shocking and repeating earlier steps. For managing other arrhythmias, particularly in the ACLS for unstable patients, you'll see in the protocols when you go through them, we'll use atropine for bradyarrhythmias. For symptomatic tachyarrhythmias on unstable patients, if they have a narrow versus a wide complex tachyarrhythmia. For narrow rhythm tachyarrhythmias, we'll look at vagal maneuvers or adenosine. For irregular narrow complex issues, sometimes you'll see diltiazem, or AFib, for example, you'll see AV nodal block with diltiazem or verapamil or a beta blocker or digoxin. For wide complex tachyarrhythmias, ventricular arrhythmias, often the first choice is going to be to go, particularly if there is for torsades, is to go with mag sulfate, particularly if they're a prolonged QT or they have the classic torsades look to them. Adenosine would only be used for wide complex if it's irregular and monomorphic. And then amiodarone is typically going to be used for other wide complex tachyarrhythmias when needed. You'll get much more of this experience when you get ACLS. It's not a focus in this block, but what we wanted to do is to give you sort of introduction to the familiarity with some of the drugs there.
Like with the other presentations in cardiology, here's supplemental content for late 2023. The same practice clinical practice guidelines from the HA and ACC, and the levels of evidence. Really, the rest of these slides are identical to what we've sort of alluded to in the last presentation on antithrombotics update. A review again of the very same slides, antiplatelet therapy without anticoagulants, antiplatelet therapy where the recommendations are no benefit or harm related to use of antiplatelet therapy without oral anticoagulants. A set of guidelines that talk about the combination of antiplatelets with oral anticoagulants, the role of the duration of antiplatelet therapy depending on indication, the criteria or guidelines for risks of these agents in pregnancy and lactation, and then more, again, the guidelines for medical therapy for relief of angina and revascularization, and revascularization PCI versus cabbage therapy. And again, the subsets of guidelines and recommendations related to the etiology of angina. As we look at the pregnancy issue here, just note that as far as the antiarrhythmics go, metoprolol, adenosine, metoprolol, DIG, and lidocaine are all considered safer in pregnancy, and those are listed here on this slide set. Finally, again, the doses you would expect in clinical rotations next year to have some familiarity with the typical doses used.